Payson Flattery. I'm a naturopathic physician. I'm also a chiropractor. I've been practicing regenerative medicine for about 18 years and primarily here in Central Oregon. Regenerative injection therapy stimulates your body's own innate biological pathways or mechanisms to regenerate damaged or degenerated tissue. In effect, what we're doing is we're taking this kind of chronic low-grade inflammation and we're pushing it back into an acute phase, giving the body a second chance to heal. This often provides long-term relief, but it's often hard for patients sometimes to understand that the therapy is going to take time. It takes a while to lay down your tissue. As many of you know, the healing cascade is, it can last up to 2 years. So most of these patients will realize full benefit between 6 and maybe 8 months. Generally speaking, they should start to see some change in their pain within the first 6 weeks. These are the therapies I'm going to be discussing: prolotherapy, platelet-rich plasma, stem cell, both mesenchymal and hematopoietic, as well as perineural injection technique, which is kind of the new kid on the block. This therapy basically has been shown to downregulate neurologic inflammation and break up cross-links over C fibers. Prolotherapy has been around for probably, I guess, close to 70 years now. There's multiple textbooks written on it, the first being that which was called ligament and tendon relaxation, treated by prolotherapy. The feeling is that a lot of people have pain secondary to ligamentous instability, and I think most physical therapists, when it comes to low back pain and joint issues, would agree with that. Prolotherapy involves the injection of dextrose, varying solutions from 10% to 25%. 25% is generally reserved for intra-articular injection. It basically it stimulates the release of specific growth factors. I have those listed here. I know I didn't provide any citations through the slides, and I apologize about that, but I do have at the end a website that has all of that information compiled. It's Dr. Reeves' site, and he's kind of organized all of the best conducted studies. So prolotherapy is inexpensive. There is some post-procedural pain, and if many of you in this room probably have heard it, it sometimes hurts having it done because it's delivered in a way where we're not just going after the pain generator, but we're going after the connective tissue matrix to try to stabilize the joint complex. It can be used in the case of tendinosis as well. PRP, which I'll discuss next, seems to excel better in that arena. There's been multiple level 1 and level 2 studies. So this therapy, even though most people consider it experimental, it's really not an experimental therapy anymore. It's also taught now at some medical schools throughout the United States. It generally requires 2 to 6 injections. These are spaced at 4 to 6 week intervals. And like I said, it takes time, so patients have to be patient. And they typically will have increased pain post-procedurally, and that usually lasts for a couple days, sometimes as long as 2 weeks. PRP is probably what most people in this room have been hearing about. I've been doing PRP for roughly 12 years. It has really kind of taken off, I think, and there is more science. I just checked on PubMed. There's 1,100 studies now on PRP. It involves the injection of platelets into an area. Those platelets hit the tissue, they degranulate, just like in a normal injury, and they release growth factors. That also causes an activation of local stem cells, which typically in a really chronically inflamed environment, those stem cells are turned off. So it's kind of turning back on, tricking your body into thinking it's been injured. There are some standardization issues with platelets. Generally speaking, platelets are concentrated 2 to 4 times, in some offices 6 to 10 times normal blood counts, and so it's very dependent on solution, so concentration basically, as well as volume. You can see here there's activation of local stem cells. It's delivering growth factors, including the long list. The one other advantage of PRP is that it contains fibronectin and also integrin, and this is great because it creates a scaffolding for cells to move across. So it does a better job of kind of bridging micro tears, and can be used for low-grade rotator cuff tears. Usually, I would say less than 10 to 15% in the rotator cuff. Requires fewer injections, 2 to 3, spaced at 6 to 8 week intervals. This therapy can be very painful post-procedurally, especially in areas of the supraspinatus in the shoulder, and patients generally need medication post-procedurally, and unfortunately that is usually an opiate. Usually five pills usually gets them through. Stem cell. Stem cell is obviously really controversial, and I think there's a reason for that. In clinical practice, everyone's doing stem cell differently, and I think patients have this real unrealistic expectation as well as kind of misconception about what stem cells are going to do for their joints. Basically, I think the expectation is that, oh, I'm going to get a stem cell procedure and it's going to regenerate my joint and I'm going to be fine, and that's really not the case. The other issue about stem cells is that there's a lot of research going on about them, but the way they're delivered in the clinical setting is very different than the way they're being delivered in the research setting. Generally, it involves lipoaspiration or a bone marrow harvest, and fat has been shown to be a better source of stem cells because it has a lot more mesenchymal stem cells, about 500 to 1,500 times more than bone marrow. Bone marrow has hematopoietic cells, which are necessary for new tissue regeneration. For new blood vessel regeneration. Mesenchymal stem cells are involved with cartilage, ligament, tendon, and bone regeneration. Currently, it's under FDA scrutiny in the clinical setting, and we'll see what happens with that. There are some other products, Amniofix and some other commercially available stem cell products. These products basically, in my clinical experience, do not perform as well as autologous stem cells. So perineural injection technique involves the injection of 5% dextrose in sterile water. This is a therapy that has been shown to influence the TRPV1 receptor, also known as the vanilloid type 1 receptor, or the capsaicin receptor. We're not sure specifically how that is happening. We know it's not a direct binding to that receptor, but we do see that it's downregulated, and there is a kind of normalization of tissue homeostasis with decreased inflammation. The great thing about this therapy is that it's fairly easily delivered. It doesn't require a lot of technique, and it's done subcutaneously and into the fascia. Most people that have had chronic inflammation basically have developed collagen cross-linking over their C fibers. This causes compression, and this causes pain. And so by going in and hydrodissecting these tissues, basically expanding them so that we free up the C fibers, we see a normalization of that tissue and downregulation of pain. It's all based on Hilton's Law, and Hilton's Law basically states that the C fibers surrounding the joint basically really come from the joint. So it's your body's mechanism of stabilizing the joint when there's irritation within the joint. These injections are typically once a week, 3 to 6 injections usually before patients see significant change. So who's a candidate? I hear from patients often, why wasn't I told about this therapy? And they're frustrated, they're angry that they've been told that they had no other options other than pain management or surgery. And this therapy basically works extremely well in those patients that have had pain for greater than 4 months, anyone with chronic pain, anyone with failed back surgery, Facet syndrome, patients with mild to moderate osteoarthritis, tendinopathy, including tendinosis and partial tear, knee osteoarthritis, post-surgical pain. We can go in with that 5% dextrose, hydrodissect the scar, and oftentimes patients have a significant reduction in pain. There are patients that have comorbidities that contribute to prognosis, and so those are things to take into consideration if you're referring to a regenerative medicine specialist. I listed contraindications as well as relative contraindications as well. Most of this research is compiled on Dean Reeves' site. It's a great website. He basically has all of the regenerative med studies that have been performed that are of any quality. PubMed is another option. Thank you.